Hi, my name is Angela Craig, and I am a clinical nurse specialist in critical care. I'm a medical science liaison for Baxter, and I speak to the science and evidence of fluid management. One of the areas that I love to speak about is sepsis, and I chaired my hospital sepsis team for many years and helped develop all the protocols related to that. And so I like to integrate CMS, national guidelines, value-based purchasing into a presentation to try to help you make sense of it all. As far as work with sepsis, I absolutely enjoy it, and I have enjoyed it in my past, and I still try to help occasionally in my hospital, but I also help my hospital become sepsis disease specific certified with the Joint Commission. And so this is very much a passion of mine. So as we go along, hopefully this will really bring some clarity to all of this. And if you have questions, I will have my email at the end of this presentation where feel free to reach out to me. As far as my financial disclosures, I am full-time with Baxter in Medical Affairs as a medical science liaison. I am a PRN clinical nurse specialist for Cookeville Regional Medical Center, their intensive care unit, and their CVICU, and I am an independent consultant PRN. My non-financial disclosure is I am a Sepsis Alliance Advisory Board member. This presentation has been approved for one contact hour for nurses. A link to obtain your certificate will be available at the end of the presentation. SACS Healthcare Communications is accredited as a provider for continuing education, provided approval by California Board of Nursing, and support for this activity has been provided by Baxter. Our objectives today are to analyze and contrast the differences in the components of the National Sepsis Guidelines and the CMS Guidelines. We're going to summarize elements to value-based purchasing and how this affects hospitals in the USA. And we're going to discuss the requirements of the 1 hour, 3 hour, and 6 hour sepsis bundles. And then we'll wrap it up with a review of a case study with a focus on fluid management and how to reach the fluid goals based on the national and CMS guidelines. So let's start by talking about what is CMS. CMS is the Centers for Medicare and Medicaid Services, and it is the U.S. federal agency that works with the state governments to manage the Medicare program. They administer Medicaid and the Children's Health Insurance Program, and they have standards, which are core quality measures that are set forth by CMS where hospitals must comply or they will be penalized. So what is new with CMS? Well, when I say new, many of us already know about the value-based purchasing, but let me just explain it. So there are domains within CMS and domains within this value-based purchasing, and you can see the document over on your right. And there are different sections, and the sections that we're going to talk about primarily is in this purple area, the lilac area, and this is in the same area as the CAUTIs and the CLABSIs and the MRSAs and the SSI, etc. You'll see it there, and at the very bottom you'll see sepsis, and in the next slides I'll kind of make that larger so you can see it. But there is a baseline period for sepsis. The baseline period for sepsis was January 1st, 2022 to December 31st, 2022. Now, then there was what's called the performance period for sepsis. And guess what? January 1 of 2024 to December 31st of 2024 is when that time period was. So there are these achievement thresholds for sepsis, and what they're looking at is determine if your baseline period for sepsis, how well you did versus how well you did during the performance period. Whichever is better is what they'll allow you to use to determine the cost related to whether you will be reimbursed or if you will be penalized. Now, the achievement threshold for sepsis is 0.597482%, slightly above the current national average of 58%. So I need you all to think about your hospital sepsis scores with CMS and think if you are at the 59th percentile. If you are, you're probably going to do pretty good this first round. If you're not, then you may very well get penalized. And then there's this benchmark for sepsis. The benchmark represents the top performance standard for the measure and reflects the national top decile performance. Now, if you look here at the, this is larger here, you can see sepsis down here, and our benchmark is way over at 80, right around 84 percentile, or the 84th percent average. So notice your achievement threshold needs to be at least 59% and or anywhere up, and if you're in the higher echelon, that's more like around 84%. So what is SEP1? SEP1 is shorthand for the Severe Sepsis and Septic Shock Management Bundle. And what it does is it lays out guidelines for frontline hospital clinicians who are fighting sepsis. And it really focuses on timely interventions, timely recognition, and life-saving therapies. And it emphasizes the timing and how critically important that timing is about saving lives and limbs from sepsis. We know it's all about time. Every hour of delay before a septic patient is treated is associated with a 4 to 9% increased risk of mortality. So we want to do everything we can to identify this quickly and to treat it quickly as well. So this is what the CMS Sepsis Guidelines front page booklet looks like, where it has all the definition measurements in there. And I just wanted to let you know, this is based on the latest version, version 5.17. And historically, this had been updated every 6 months. It would go for the first 6 months of the year, and then they would update. But I did notice in this last revision, it is for the publication for 12 months. So we'll see if there's any changes. You know, you never know if they will have other changes, but currently it says it's from January 1st, 2025 to December 31st, 2025. So hopefully it'll be solid for the next year. Now, based on CMS, within 3 hours, we want to have completed a lactate level, getting blood cultures prior to administering those antibiotics, giving broad spectrum antibiotics, and administering that 30 ml per kg of crystalloid if the patient is hypotensive or has a lactate of greater than or equal to 4. However, I will tell you there are some changes that they have made with that is the standard that they like, but there's also some reasons why you may deviate from the standard. So that is why it is so important that you know what these guidelines say. Now, we're going to go over those a little bit in detail, but what they're looking at is the time of severe sepsis or septic shock definition, and we'll go over those definitions. But when it says to be completed within 3 hours, that means from the time it's determined that the patient has severe sepsis or septic shock, whichever comes first. Now, what we've done at our hospitals, we've just decided that presentation time to the emergency department, if there's a known or suspected infection, we try to go ahead and work them up very rapidly. And the staff don't have to try to figure out exactly what time 0 is based on the definition, but based on their presentation. So we feel like that has helped us in our hospital versus having to know, is there a known or suspected? Are there search criteria? Is there organ dysfunction? You just move forward to try to find those answers. Now, within 6 hours, CMS says that we apply vasopressors for hypotension that does not respond to initial fluid resuscitation to maintain that mean arterial pressure of greater than or equal to 65 millimeters of mercury. And in the event of persistent hypotension after that initial fluid administration, if that MAP is less than 65, or if that initial lactate was greater than or equal to 4, there is a reassessment of volume status and tissue perfusion that has to be documented. And I will share with you what we've done at a hospital I've worked with for many years to try to facilitate getting that goal. Now, the other thing within 6 hours that has to be done is to remeasure that lactate if the initial lactate is elevated. And the initial elevated lactate would be greater than 2. Now, then there are what's called the international guidelines for sepsis. And I know that CMS is important for our hospitals, but it's also very important that we understand what the international guidelines are. And to be honest with you, many of the CMS criteria are taken from the guidelines. And you'll see that as you become familiar with both. But I do recommend that your sepsis teams and people who are working with the sepsis population really need to know what the Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock say and what the rationales are. And I've got a binder that, or a little folder that I have, and I've got mine all tabbed up to where I can quickly and easily just go to the tab that I need to if a provider is not understanding the rationale, so we can have a nice scientific discussion on why that's important. Now, what you see in front of you are the 2021 guidelines. These typically are put out every 4 years. So I'm expecting sometime in 2025 for the next set of Surviving Sepsis Campaign International Guidelines to come out. Now, based on the Surviving Sepsis Campaign, because we're really looking at both, right? We're looking at CMS and the Surviving Sepsis Campaign guidelines. And what you're going to find is they focused more on an hour one bundle. And I really like this for the hospitals to do, because I think if you do these things in 1 hour or in that first hour when they present, then hopefully you'll have more compliance with this bundle. But I think it's really important that you do, we talked about measuring that lactic acid level, obtaining those blood cultures before you give antibiotics, giving those antibiotics, and then begin to give your rapid fluid bolus. Now, there's going to be some times where, like I said, we're going to talk about what CMS allows, but based on the CMS guidelines, it is that 30 ml per kg of fluid administration if they meet that criteria that we mentioned on the previous slide. And then the other thing they mentioned, and I really like this, is that applying those vasopressors if we find that the fluid is not bringing up their pressure quickly. So not necessarily waiting till the 6 hours you get from CMS, but really trying to make sure your patients don't become hypoperfused because of that low blood pressure. So starting those as you see fit, and maybe actually within hour one, possibly. Now let's just talk briefly about the definitions. Now this is just a highlight of the Surviving Sepsis Campaign over the years 2012, 2016, and then 2021. In 2015, the definitions changed and they took out the severe sepsis category. So it makes it a little challenging because CMS still has sepsis, severe sepsis, and septic shock. So most of the hospital that I'm still affiliated with, we go with sepsis, severe sepsis, and septic shock. Many providers are just documenting potentially sepsis or septic shock because they know that's what the guidelines, national guidelines say. So, but you have to be familiar with what the definition is of those, so we'll go over those. I just wanted to make sure you are aware that there are differences here between these two guidelines. So let's briefly talk about the CMS definitions. So there are sepsis, severe sepsis, and septic shock in our range of how you can start with sepsis and end with septic shock. CMS focuses on severe sepsis and septic shock. So we really don't have per CMS a per se definition for sepsis because they really focus on severe sepsis and septic shock. But we do have some guidelines that focus on sepsis. So to help us with our definitions, I want to start by mentioning SIRS criteria, the systemic inflammatory response syndrome. We know that this is what we have to utilize, and it does say in the guidelines, it mentions that we will utilize SIRS, or that we should utilize SIRS, but I will tell you it's not totally specific. There's nothing that's perfect out there to help us really identify sepsis, so this is what we have to work with for now. But it is the systemic inflammatory response syndrome. Now, we know that this is the body's result to an insult. It can be caused from a chemical, traumatic, or an infectious stimuli. It is a reaction to a situation and a group of symptoms that consistently occur together. So known or suspected infection and 2 or more SIRS criteria are pretty commonly thought to be sepsis. So there is a challenge with SIRS as sepsis criteria. Remembering that SIRS is nonspecific, it can be caused by ischemia, inflammation, trauma, infection. It's not always related to infection. And I want to remind you what the definition is of sepsis based on the national guidelines, right? Sepsis is a life-threatening organ dysfunction caused by a dysregulated response to an infection. Historically, we've said known or suspected infection and 2 or more SIRS criteria equates to sepsis. Now, I want to also share with you that what we're talking about today is adult-based. CMS focuses on the adult patient, 18 years of age and older. However, there are a whole set of sepsis criteria for the pediatric population. And if you work with that population, I highly recommend that you get a hold of those guidelines and then you read about that. And feel free to reach out if you have any questions. But I am focusing specifically on adult. Now, we are also, I did include in here the non-pregnant criteria versus the pregnant 20-week through day 3 post-delivery criteria. The SIRS criteria are different. Some of the organ dysfunctions are different. So you will want to make sure as you're developing those protocols for that specific patient population, you'll want to make sure that that is updated appropriately. So now that we have discussed sepsis, let's talk about severe sepsis. And severe sepsis, based on CMS, is a known or suspected infection, 2 or more SIRS criteria, plus organ dysfunction. Now, I want to mention that known or suspected, so suspected counts everyone. We can move forward with just a suspected sign of infection, okay? So whatever that is for that patient, if you suspect it, speak up, right? Very, very important. So how can we identify organ dysfunction? Well, CMS has given us some very specific criteria for organ dysfunction, but I want to just kind of make it simple. Think about your normal body systems and how they function. If all of a sudden the patient starts having some altered consciousness or altered mental status, then something's going on and something's affecting CNS, right? So then I say neuro's down. If my patient SAT is less than 90% or increasing oxygen requirements, now CMS usually mentions that they're on mechanical support, but for us at the hospital I work at, we even like to say for increasing oxygen requirements because we don't want to wait till they're on the vent to say that that organ's down. You can see there's multiple others there. I'm not going to read all of them, but this is how you determine. You look at your labs and you compare them to your patient, and then you think about the body systems, like your lactic acid, that's metabolic. So if it's greater than or equal, if it's greater than 2, then you know that you've got metabolic down. If your blood pressure is low, then cardiovascular is down, etc. I hope everybody gets that. And I think it's also important to remember the differences between the pregnant mamas as well. So organ dysfunction for the non-pregnant patients is different than organ dysfunction from the pregnant 20 weeks through day 3 post-delivery patients. And so I have included that here and for you to review. I'm not going to read every single one of these. They're different based on the patient and what's going on with the patient. Now, septic shock is the worst of all, right? It's a severe sepsis plus, so severe sepsis, known or suspected 2 or more SIRS criteria, and organ dysfunction, plus any of the 2 items below, a lactate greater than or equal to 4, or persistent hypotension evidenced by persistent hypotension or new onset of hypotension present within 1 hour after the targeted ordered volume of crystalloid fluid was completely infused. Now, this is based straight off of the CMS guidelines. So that is the definition that they are utilizing to guide our treatment care based on. Now, let's look at initial resuscitation from the Surviving Sepsis Campaign, the national guidelines. So with the initial resuscitation, you can see that in 2016 and 2012, it was the same. And then for 2021, it is for patients with sepsis-induced hypoperfusion, we suggest that at least 30 mils per kg of IV crystalloid fluid should be given within the first 3 hours of resuscitation. We suggest using balanced crystalloids instead of normal saline for resuscitation. So I think it's important to remind everyone about balanced solutions instead of saline. The other thing I want to mention, there was no change in this section down here about dynamic resuscitation markers, doing a passive leg raise, targeting that mean arterial pressure of 65 millimeters of mercury, reassessing that hemodynamic status to guide resuscitation and to normalize lactate. And they suggest as well to use cap refill to assess resuscitation. That is the one change that they did have. Utilizing capillary refill. Now, let's talk about what CMS requirements are for fluid bolus. I just wanted to share with you a picture of what an abstraction note looks like from CMS. It is robust. There is a lot to know, and this is just part of the abstraction page for this. This is just a sample guideline. Now, I'm just going to keep scrolling because look how many pages for this one abstraction page about fluid. So we're not obviously going to read every single part of this, but I do want to focus on one area that is a little bit more recent. If for some reason that your patient has documentation that there is an implanted ventricular assist device prior to or at the time of identifying the need for crystalloid fluids, regardless of the volume and rate of crystalloid fluids ordered, or if the physician, advanced practice nurse, PA, or nursing documents indicates patient or authorized patient advocate has refused IV fluid administration prior to or within 6 hours following presentation of septic shock, or the physician, APN, PA, or nursing documentation indicates no crystalloid fluids were ordered because the patient was not volume or not fluid responsive. Documentation, though, has to indicate that invasive or non-invasive measurements of cardiac output, cardiac index, stroke volume index were used to determine the patient was not volume or fluid responsive. Those patients do not have to receive the 30 ml per kg of fluid. Now, I'm going to share with you another document that may be helpful to get all of this fluid straight, because you say, well, Angela, you told me that the guidelines said 30 ml per kg, but now you're saying you don't always have to give 30 ml per kg, and it's really a difference between the national guidelines and CMS. But CMS has given some liberty based on an individual scientific assessment that you can back off if you have that criteria. So let's review that. This is just a sample severe sepsis septic shock progress note. This is a paper version. We have actually put this into our electronic medical record on the provider side. Now, this is just the screening tool of the patient. Let's move on. Let's look at the fluid plan for the patient, since that's the section we're on. If there are multiple ways you can choose how much fluid to give patients based on CMS. The fluid plan for patients receiving the 30 ml per kg of crystalloid, you can go ahead and mark that and just give 30 ml per kg if the provider feels that is safe. Now, if the patient is obese, has a BMI greater than 30, the provider can choose to use ideal body weight for the 30 ml per kg of crystalloid fluid volume. You do need to document that ideal body weight, and you do need to document that that patient is either obese or has a BMI of greater than 30. Now, for those patients to receive less than 30 ml per kg of crystalloid, per CMS, they must document the specific volume or weight-based volume they want the patient to have, and then the reason for not administering that 30 ml per kg. So I wrote some of the suggestions that were in the manual. Concern for fluid overload, heart failure, renal failure, blood pressure responded to lesser volume, or other. I think this is really a documentation thing. Many times we do what we feel is appropriate, or the provider orders what they feel is appropriate, but they don't document why. You have to document why, or these will fall out. It is just a booger. You've got to document well. Now, then, if patient is not to be receive fluid, it can only be based on those 3 items that I mentioned. The patient has an implanted ventricular assist device, the patient or patient advocate fluid refusal, or the patient is not volume or fluid responsive based on measurements of stroke volume index, cardiac output, and cardiac index. And you can do these passive leg raises or the small fluid boluses we'll talk about. You can do those non-invasively. It's very easy to do in an emergency department scenario. So don't think that just because you're in the emergency department that fluid monitoring is too hard. It's really not. It is really very simple to do, and we're going to go over that in the scenario. This is the rest of that progress note. I had mentioned that if the patient meets criteria for septic shock or has that lactate of greater than or equal to 4, or they're hypotensive after that fluid, then you have to do a reassessment of volume status and tissue perfusion. They can either document the reassessment of volume status and tissue perfusion that it was completed post-fluid administration, or one of the following can be done. Somebody can document a CVP or an SCVO2 or an SVO2 measurement, an echocardiogram or cardiac ultrasound, or an assessment of fluid responsiveness with passive leg raise or a fluid challenge can also cover you for this reassessment piece. When we talk about dynamic assessments, it's important to know what patient population may really benefit from a dynamic assessment. And I usually say those patients who have a known or suspected infection to where you're not sure if they can benefit from fluid or not, if you're going to need to give large sums of fluid potentially. If your patient has hypotension or hypoperfusion, then those patients you really want to know if by giving them fluid, their body and their heart can take and receive that fluid and help forward flow so that it improves perfusion. The only reason to give a fluid bolus is to increase stroke volume, which then increases cardiac output, right? Heart rate times stroke volume is cardiac output. So we can do a dynamic assessment 2 ways. I'm going to talk first of all about the bolus. Now, personally, I like the passive leg raise because you can develop that as a nurse-driven protocol. You can also develop the bolus as a nurse-driven protocol, but some institutions prefer boluses to be ordered by physicians, and others prefer that the nurses can do a PLR and then report that back to them. So it's going to be very specific on the culture at your institution. But if you are going to do the bolus, it's a 3-minute, a very fast bolus, but you do have some baseline time based on what technology you're utilizing. There is non-invasive hemodynamic monitoring. You will need a monitor that allows you to monitor cardiac output or cardiac index, stroke volume or stroke volume index. And so you do a baseline to get your baseline values. If you're giving a 250 bolus, you want to do that in less than 5 minutes. The idea is to give it in quickly. It's about speed. It's very important that that is given quickly so you can see really quickly if that heart is going to take and receive that volume and help forward flow. What you will see if the heart can receive and accept that and help to improve perfusion is you will see that stroke volume increase by 10% or greater. Stroke volume or stroke volume index. Now, you can also give a 500 ml challenge, but it needs to be in less than 10 minutes. So in order to do that, it's going to be faster than 999 on the pump. You will need to put this on a pressure bag and squeeze it in. All right, that is one kind of dynamic assessment. The second type is the passive leg raise. And once again, you would get the technology on the patient and you would do a baseline to get their baseline numbers. Now, you're going to want to do the baseline with the patient in that semi-recumbent position. So you want their head of the bed up about 45 degrees, trying to get all that volume away from their heart, almost down to their lower extremities, so that when it is time after you get the baseline, you lay the patient's head flat, you lift their legs, and there's a little lift that you can put underneath their legs, keep their legs elevated so that volume quickly goes back to their heart to see if they have a 10% increase in stroke volume or stroke volume index. So this is the visual. On the left side of the screen, you'll see the passive leg raise device that will allow you to hold the patient's legs up. And then here's the an example pressure bag. Now, what I will tell you is if the patient does not respond well with a passive leg raise, the beauty in that is that it is reversible. Just take out that lift, lower the extremities, lift the head, and let that volume go back down to their lower extremities. Now, if you give a fluid bolus and there's a poor response, you may have to give a diuretic or something to get that fluid off. So that is another reason why I really like that passive leg raise. Now, vasopressors are the next section on based on the Surviving Sepsis campaign that we're going to discuss. Now, if you look here, you'll notice that the target mean arterial pressure is 65. That has not changed from 2016. Norepinephrine is the vasopressor of choice. Epinephrine, if not at target map, or vasopressin to reduce norepinephrine requirement and avoid dopamine in most patients. Now, one of the things that is different for the latest guidelines is that they suggest starting vasopressors peripherally to restore MAP rather than delaying initiation until central venous access is secured. Back in the day, we used to always want to make sure patients had central lines if they were going to have vasopressors going, but there has been a plethora of studies done to show that we can safely do this. Now, there needs to be a policy at your institution for the safety of peripheral vasopressors and where to place those appropriately, how to look at them. I know at the hospital I'm still affiliated with, we have a little label that goes right on there. We make that extremity be visual at all times and not underneath the covers, and have a little label that says peripheral vasopressors. So there are some things you can do to really make sure that you do this safely and do this well. Now, based on CMS, there are requirements for vasopressors. And once again, I'm not going to read all of these, but I want you to see the magnitude of some of these requirements. So this is just an example of what is required, and this is just for vasopressor administration. But there is very specific time periods when this need to be started by, and we need to make sure that the abstractors know exactly where to find this information so that they can make sure to give you all the credit that you deserve. Now, the next section I'm going to go over just briefly is antibiotics. And based on 2021, there were some changes in the antibiotics section. For adults with possible septic shock or high likelihood of sepsis, they recommend administering antimicrobials immediately, ideally within 1 hour of recognition. But for those with possible sepsis, they suggest a time-limited course of rapid investigation, and if concerns for infection persist, provided antimicrobials in 3 hours. For patients at high risk of MRSA, they recommend empiric antimicrobials with MRSA coverage. They suggest against empiric MRSA coverage if the patient is at low risk. So once again, taking a moment to really think, does this patient have a known or suspected infection? If it's a high suspected, then they would get that antibiotic within an hour. Now, what is CMS requirements for antibiotics? CMS requires that the patient get an antibiotic within 3 hours of severe sepsis or septic shock presentation, whichever comes first. So there are very specific antibiotics that are required, and you can see here's just the start of that requirement, and here's some more. But the abstractors have to be very current and know exactly what is required. I'm not going to go over every one of the requirements. However, I do think it's really important that maybe your order sheets for the providers have specific antibiotics based on what disease or what organ is affected, so that they can make sure they're giving the correct antibiotic. Antibiotic stewardship should be very involved in your sepsis program and in these orders for antibiotic administration. So as we talk about a case study, I want to, before we go into this case study, talk about the 3 levers of perfusion and try to explain that a little bit. We know that it's all about perfusion with our patients, right? Blood pressure is exactly that. It is pressure. It does not equate to flow, right? So it's super important that we look at flow parameters. When we talk about preload, I want you to think of stroke volume and stroke volume index. Think of V for volume. Normal stroke volume, think normal heart rate, 60 to 100 mils per beat. And that's the one that I memorize because I feel like it's easy to remember. And what you want to think about is this patient hypoperfused or hypotensive? If that is yes, then we need to determine if it's a preload problem. So we would perform a dynamic assessment to assess fluid responsiveness. Do they have a 10% or greater increase in stroke volume or stroke volume index? The next lever is afterload. Looking at your total peripheral resistance index to determine the resistance that heart has to pump against. I really like this number because it helps me know how constricted the patient is. The higher, the more constricted, the lower, the more dilated. So normal TPR is 800 to 1200. And the last lever is contractility. So looking at cardiac output and cardiac index, thinking C for contractility, cardiac output normals 4 to 8, normal cardiac index 2.5 to 4. And if it's low, you want to ask the question why. Does this patient need fluid? It can be low because the patient needs fluid. Hopefully we will have already assessed that by doing a dynamic assessment. Or do we need an inotrope? So we're going to take a few moments and go through a case study to talk through how we can look at these 3 levers of perfusion to help this septic patient. So let's start with our case study. Doesn't this look like a patient we might see in our ICU on the vent and needing some support? So here we go with our case study. So we have a 60-year-old female who arrives to the emergency department with a persistent cough and fever. She states it's been over a week of symptoms and she thought she could fight the infection off by rest and Tylenol. She's hypoxic, was started on BiPAP, but remained hypoxic, so was intubated. And the patient is also started on the sepsis bundle in the emergency department. Patient has a temperature. It's elevated. Blood pressure is low with a mean arterial pressure of 53. Heart rate's 125, elevated. White counts elevated, 20,000. Lactate elevated, 6.0. BUN 30. Creatinine elevated, 2.2. Procalcitonin elevated at 4. When we think back to our criteria for the definitions, this patient has a known or suspected infection, has multiple SIRS criteria already. You can see here the white count's 20,000, the temperature is 1015. We also have multiple organ dysfunctions already. Blood pressure is low, there's one organ dysfunction. You can see the lactate is 6. So that's an organ dysfunction. Metabolic creatinine's elevated at 2.2, so that's an organ dysfunction. So we're already in the shock category, right? Known or suspected, 2 or more SIRS, and that lactate is greater than or equal to 4. So we are in septic shock. We're very sick. Patient was diagnosed with pneumonia post x-ray, and the lactate and blood cultures were drawn in the emergency department. The patient received antibiotics, and they administered 1 liter of IV fluid, and then they connected the patient to the non-invasive hemodynamic monitor right there in the emergency department to give fluids based on the patient fluid responsiveness, because we can do this now based on CMS guidelines, right? So you may not have to give that full 30 ml per kg. The guidelines do, though, suggest 30 ml per kg if you're in this shock state. So our first question should be, is this patient hypotensive or hypoperfused? Well, we've already discussed that the patient's mean arterial pressure was 53. Notice we have the patient connected to the non-invasive hemodynamic monitor. Our stroke volume is only 45. Remember, normal heart rate is the normal rate, 60 to 100. Low stroke volume, that means that's that amount in the left ventricle before it ejects, or the amount that ejects with each beat, is what's in there. So it's a small amount, right? TPR, total peripheral resistance, that surrogate for SVR, is low here. Normal is 800 to 1200. So when you think about it, the lower it is, the more dilated the patient is. And this happens a lot of times in our septic shock patients. Now you can see the cardiac index is adequate right now at 2.7. So since the patient is hypotensive or hypoperfused, we do a passive leg raise or a fluid bolus. In this case, let's just say that we're going to do a passive leg raise. There's a nurse-driven protocol, and they do a passive leg raise. When the passive leg raise is completed, the increase in stroke volume is 4.4%. Is this patient fluid responsive? Hopefully all of you guys are saying no, right? Is this patient fluid responsive? No. If it's 10% or greater increase in stroke volume, then yes, but they are not fluid responsive. So you can see here where we go from 45 to 47. It's simple math, but your technology will do the work for you, okay? So let's think about what we should do since we're not fluid responsive. So based on your clinical findings, what should we consider next? Do we want to think about a vasopressor? Do we want to think about a positive inotrope? Do we want to give more IV fluids, even though they're not fluid responsive? Or do we want to give a vasodilator? So let's talk through these. Now, when we think about what's going on with the patient, we have a low mean arterial pressure. We also have a low stroke volume. So remember how we talked about looking at preload first, and we did a passive leg raise, and they were not fluid responsive. So we know that that heart, for some reason, cannot take and accept that fluid to help improve stroke volume. So fluid is not the answer. Also notice that your TPR, your total peripheral resistance, is low. So this patient is more dilated. So they may need to be tightened up. So I hope you all picked A, start him on a vasopressor. And we all know that the vasopressor of choice is Levophed based on the guidelines that we just went over. Okay, so the vasopressor infusion started. We increased over the next hour to the institution max dose, okay? So let's say this patient had to be up titrated frequently, was very sick, and so now we are up to a mean arterial pressure of 60, but we're at the max and it's been an hour. So we look at stroke volume, we see that stroke volume is still low, but look, TPR came up. We're in the normal range of total peripheral resistance. Why is that? Take a moment to think about it. It's probably because you added a pressor to tighten them up, right? Now, here's what I want to mention as well. I think it's really important to remember that as we titrate pressors, we have to remember it takes a toll at times, right? So as we're tightening, it's going to be harder to pump volume out of the heart, right? Because it's more constricted, or it could be harder. If they have a very strong heart, then they may do okay. So that's why we're going to monitor that cardiac output and cardiac index very closely as well. So our question we always want to ask, and here's what I want to remind everyone. Patients can go in and out of fluid responsiveness, right? It's not one and done, do a passive leg raise, and that's the answer for the next 2 days. No, they can go in and out of fluid responsiveness. So I recommend whatever technology you have, you place it on the patient, you keep it on the patient, and you monitor and you trend. I always say trend is your friend. So we can see how well they're doing with their stroke volume and their cardiac output and index and their TPR and their TPRI. So our question is this patient still hypotensive or hypoperfused? And even though we've increased to a 60 mean arterial pressure, we know that we want to keep our patient, in order to perfuse their organs, to keep that mean arterial pressure at 65. So yes, this patient is still hypotensive. So that means we do what? Say it out loud. That's right, we perform a passive leg raise, right? Or do a fluid bolus if you're unable for some reason to do a passive leg raise. So we're going to perform a passive leg raise, and after we did the passive leg raise, we get that it's only 6.1% increased. So is this patient fluid responsive? No. And you can see here we only went from 49 to 52. So, okay, so what are we going to do? Let's think about our options. Based on our clinical information, what might we want to do? Do we want to increase our vasopressor? Do we want to add another vasopressor? Do we want to add an inotrope? Do we want to give IV fluid? Or do we want to give a vasodilator? Now, I hope nobody said vasodilator because we're already hypotensive, right? And really at this point, I don't think we need to give a positive inotrope yet. Our cardiac output our index is still 2.5 and 2.6 when we did the PLR. Our mean arterial pressure is still low. We are normal as far as TPR, but we are maxed out, institution max on the first pressor. So I hope you chose add another pressor. And most of the time we're adding vasopressin as the second line agent. Okay, so we've got a vasopressor at institution max. We have vasopressin now going at a set dose, 0.04 units per minute. And pressors continued and blood pressure did improve over the next hour. MAP is greater than 65 and the TPR went up, and it went up quite a bit. Remember, normal is 800 to 1200. So now we're more on the constricted side. And remember when we talked about that vasoconstriction, as we vasoconstrict, if their heart has problems functioning, it may cause the heart to have a difficult time to pump blood out against that constriction. So you can see here in this scenario, and many septic patients end up with a cardiac issue, right? It's like they have a hit taken to their heart and they have depressed contractility at times. And in this patient scenario, that's exactly what happened. Now the lactate did decrease, so that makes me think we're better perfused, right? But after an hour, the cardiac index dropped, and also the stroke volume dropped. So now our stroke volume is all the way down to 35. Our cardiac index is down to 1.9, which we are now in a cardiogenic shock state, right? With that index so low. So our question always should be, is this patient still hypotensive or hypoperfused? Well, the patient's normotensive. However, yes, very much so hypoperfused, if nothing else, based on that 1.9 cardiac index. And the patient still does have a pretty high lactic acid level as well. So we do another passive leg raise. And the stroke volume increases by 8.6%, so not 10% or greater. So based on our clinical information, what should we consider next? Well, we know that if we increase the vasopressor, we're only going to increase this constriction, right? Which could then in turn make our cardiac index even worse. Are we going to add another vasopressor? No. Are we going to add a positive inotrope? Well, let's think about that. Would we give more IV fluid? Hopefully not, because they're not fluid responsive, and we're not going to give a vasodilator. Even though I'm more constricted, I don't want to drop that pressure. We're still kind of lower on the pressure side. So what maybe could we do for this patient? I'm going to give you a second to think about it, and I hope you chose add an inotrope, a positive inotrope. Now, pressor 1 and 2 and positive inotrope is infusing. And you can see 1 hour post-albutamine, we do have an increase in heart rate a bit, and we know it can be proarrhythmic. MAP is a little bit better, not a lot. I mean, it's basically the same. But look at the difference in stroke volume. Went from 35 to 50, and notice the improvement in total peripheral resistance. And notice what happened to a cardiac index and cardiac output. And sometimes what I find is that we reach for the vasopressors when maybe what the patient needs is a positive inotrope. So this can really help you determine which lever you need to work on. And in this case, it was the contractility one. All right, so 3 hours later, just randomly, the patient did okay for 3 hours. Now, mind you, they're still on the 3 drugs, right? Which I don't love that, but at least we're maintaining the patient's perfusion, hopefully. But notice 3 hours later, that mean arterial pressure went down to 61, and the stroke volume dropped from 50 to 42. All right, so we always ask the question, is this patient hypotensive or hypoperfused? And the answer is yes. So what are we going to do? What are we going to do? We are going to do a passive leg raise. That's right. And we find that now this patient is 14.3% fluid responsive. Now remember what I told you, patients can go in and out of fluid responsiveness. So in this case, I guess 4th time's a charm, and now the patient's fluid responsive. So what are we going to do? Which A through F should we consider next based on this clinical information? Now let's look at the numbers again. Heart rate's 110, mean arterial pressure is low at 61, 42 is the stroke volume, and TPR is normal, and cardiac index is right around 2.2. And then post PLR, you can see those numbers there. Since we are fluid responsive, let's give some IV fluid. That's right. Great answer. So we give some IV fluid. We give 500. You can see after the 500 of LR, because remember LR is a balanced solution. We give that, and notice mean arterial pressure is up to 66. Stroke volume went from 48 to 52. TPR is at 960, and the cardiac output and index is even better. So since that stroke volume is still at a low number, they went ahead and did another fluid responsive test just to see if the patient could be a little higher in their stroke volume. And sure enough, they gave another 500, and this patient did respond well. And now you can see everything's within normal, right? So great, great job, everyone. And so what are we going to hope to do after that second bolus of fluid? The new vitals are listed, and since everything is normal, hopefully we can hold tight and start down titrating those medications in hopes to get these patients off some of these vasoactive drugs and positive inotrope. I just want to mention a few resources that should be very helpful for you in your sepsis journey. One of the things I do at times is go to hospitals and do a sepsis deep dive gap analysis. And I had created one before, or had worked with some colleagues to create one as well, but I have found that this hospital sepsis program that came out in 2023 is excellent, and it came out by the CDC. There is a link there for you. You have the ability to do your own gap analysis, but a great resource for you. A study that came out of that, and I'm not going to read every single one of these statistics, but the question was, what practices have U.S. hospitals implemented to monitor and treat sepsis around the release of this CDC hospital sepsis program core elements? And you can see that many, over 5,000 hospitals responded. 78% reported having sepsis committees. 59% reported sufficient dedicated time for sepsis leadership. Some of the opportunities for us were more around this. 32% reported standard processes for verbal handoffs. So we really need more standard processes for verbal handoffs. Also, 32% reported standardized screening for new functional or cognitive impairment, and we know that sepsis can cause that, so we really need to work on that, as well as 38% provided patients with contact information for clinical staff at discharge. That's an opportunity for us. And then only 22 to 23% reported sepsis education during onboarding and annual sepsis education for CNAs and patient care techs. And we know that a lot of times those patient care techs and CNAs are the ones doing the vitals, getting those SIRS criteria. So we really need to make sure they are aware of the importance of early identification. In conclusion, modest initial progress in resource hospital sepsis programs. Many opportunities to strengthen the hospital sepsis program to optimize patient care. Really need to focus on executive sponsorship, evaluating the usability of local sepsis tools, as well as implementing processes to support sepsis recovery. And there's a few more there as well that you can review. Last, I just want to mention that we do have a medical education website. You can scan this QR code to access our website, or you can visit fluidmanagementeducation.com. You can watch videos, you can listen to podcasts, you can review the latest studies and literature, learn about research grants, etc. But this is a medical education website we would love for you to be part of, and feel free to subscribe and get a fast fluid fact that is sent to you weekly, and it's a fluid management principle you should be able to read in 5 minutes or less. So I think you'll find this to be a very helpful website. And once again, I want to remind everyone, this is a continuing education for nurses. This educational activity is approved for 1 contact hour. To obtain your CE credits, go to www.saxtesting.com/RB. You will need to register at the site, complete the evaluation, the post-test, and upon successful completion, you will be able to print your certificate of completion. And support for this activity has been provided by Baxter. If you want that CE, feel free. It will take you to a separate website. There is a small fee associated with that at this time, just to keep within our appropriate requirements for Baxter, but it's very small. If you just want to listen to it and not get the CE, that's fine as well. We're just so glad you attended and you joined us today. There are multiple references that I utilized to put this presentation together, and they are listed here. If you have any questions, feel free to reach out to me at angela_craig@baxter.com, and I would love to have an interaction with you and just connect to see how well we can better treat our sepsis patients. I just want to say thank you for your time and your attention. I hope you all have an amazing day.